The topic of this video lecture is Diagnosis of the Allergic Disorders, Laboratory Investigations. Diagnosis of IgE-mediated hypersensitivity based on the positive histories, skin tests, and on specific IgE assays. Because of the large number of potential allergens and the fact that not all allergens are IgE dependent, identifying the cause can be difficult. In vitro tests are available for allergists to identify the allergen responsible and avoid challenges, especially for patients who are simultaneously exposed to multiple allergens or have a history of life-threatening reactions. Laboratory techniques do not diagnose allergies as a disease, but instead determine the presence of sensitization, the presence of allergen-specific antibodies or cells, which may not cause clinically significant pathology. The diagnosis of IgE-mediated hypersensitivity relies on positive history, skin tests, and specific IgE. Laboratory investigations include detection of eosinophilia, cytological examination of nasal swabs and ocular discharge, allergen-specific IgE antibody, basophil activation tests, investigation of serum tryptase levels, and allergen-specific and non-specific IgG4. IgE discovery in 1967 was a significant advancement in comprehending and diagnosing allergic diseases. Normal individuals' IgE levels increase from birth to adolescence, after which they gradually decrease and reach a plateau after the age of 20 to 30 years. IgE levels above 100-150 are considered high in adults. Allergic and parasitic diseases, as well as several other conditions such as hyper IgE syndrome or drop syndrome, selective IgA deficiency, Viscott-Aldrich syndrome, DiGeorge syndrome, and IgE myeloma, increase total serum IgE levels. Approximately 30% of atopy patients have normal IgE levels, and some patients, particularly those with asthma, may have monosensitization that does not affect their total IgE levels. As a result, measuring total serum IgE is not an excellent indicator for allergen screening and should no longer be used for diagnosis as a diagnostic tool. The total serum IgE measurements lack predictive value when diagnosing a media-type allergen, whereas measuring allergen-specific IgE in serum is crucial. In vitro methods for determining IgE levels specific to house dust, animal, fungal, pollen, and drug allergens in blood serum involve instrumentally evaluating the interaction of immunoreagent, antigen, and antibody complexes using indicator taken isotopic, fluorescent, or enzyme marks through immunochemical investigation techniques. All techniques are based on the immunoassay principle. Typical immunoassay for the detection of allergen-specific IgE in 3 steps. First, the allergen is absorbed and immobilized to a solid phase. Second, patient serum is added followed by incubating during 30 to 60 minutes and several washing steps. And third, allergen-bound IgE is detected by a labeled anti-human IgE monoclonal antibody. Similar to prick tests, the evaluation of specific IgE levels should correspond to the patient's history, physical examination, and sometimes symptoms experienced after laboratory or natural allergen exposure. Despite not displaying allergy symptoms, several patients may have heightened levels of specific IgE. The advantages of in vitro tests in the diagnosis of atopic diseases are safety. The test is unaffected by skin conditions and medication, does not depend on cooperation with patient, especially a child, good reproducibility, elimination of false positive and false negative skin tests, single invasiveness, single blood sampling, The disadvantages of in vitro tests in the diagnosis of atopic diseases include more expensive than prick tests, less sensitive than prick tests, not available in all laboratories, result only available after a few days, less sensitive for food allergies, only circulating IgE is measured, cross reactions between allergens occur, and non-protein antigens are not recognized. Allergen mixtures, individual allergens, and allergen molecules are used for testing. Results are interpreted as specific IgE concentration according to hazard classes. 0. Non-detectable sensitization, low level, medium level, high level, very high level, and excessive level. The immunocap system from Thermo Fisher Scientific in Uppsala is widely regarded as the gold standard for diagnosing allergic conditions via in vitro methods. This system employs a solid phase immunoassay with chemiluminescence detection. It can analyze kits with a large number of allergens, detecting even ultra-low IgE content. The system's singular testing capability for multiple household inhalation and food allergens enables the swift screening of sensitization for the top and for the top infant in the initial round. The subsequent stage involves targeted diagnosis using detection to individual whole allergens and all their components, helping to identify the suspected allergy triggers. Allergy component diagnosis ensures proper selection and forecasting of the effect of specific immunotherapy. Recently, allergen microarrays have also come into existence for in vitro diagnosis, extensively tested in research and medical practice. Basophil activation tests. The two primary effector cells in IgE-mediated allergic reactions are tissue mast cells and peripheral blood basophils. These cells may also be involved in pseudoallergic or other types of allergic reactions, including non-immunological or non-IgE-mediated stimulation and complement activation. The current methods to evaluate basophil activation are based on the identification of factors released during cell activation, like atreans, histamines by ELISA test, and the expression of activation marks, CD63 and CD203 by flow cytometry on cells. This test can be conducted both after in vitro stimulation, which involves incubating cells with an allergen, and within 24 hours of anaphylactic reactions. Investigation of serum tryptase levels. This method is employed to confirm the occurrence of anaphylaxis. The basal level of tryptase in blood is typically low, measuring less than 11 microgram per liter. Following an anaphylactic reaction, the tryptase concentration increases. The detection of eosinophils in various body fluids is a reliable indicator of allergic rhinitis, asthma, and eosinophilic bronchitis. It's important to consider that high levels of eosinophils in the blood may suggest different underlying conditions such as parasitic infestations, infections, neoplastic, autoimmune, and hormonal diseases. Additionally, the absence of eosinophilia cannot be used to rule out an allergic reaction. Allergic rhinitis and asthma frequently produce mild eosinophilia, while atopic dermatitis may cause a significant eosinophilia if it affects a large part of the body and is associated with atopy. Cytological examination of nasal swabs and ocular discharge during an exacerbation of rhinoconjunctivitis is a viable means of identifying eosinophils. Nonetheless, its practically is limited due to the presence of eosinophilic in nasal secretion for other conditions. Nasal polyps, non-allergic rhinitis with eosinophilic syndrome, and bronchial asthma. Despite this limitation, this method is widely utilized in practice. In patients who register an eosinophil count of more than 5%, a negative nasal allergen provocation test can support the confirmation of a diagnosis of non-eosinophilic allergic rhinitis. Conversely, if neutrophils are identified, there is an indication of the infectious nature of the process. IgG4 is a unique molecular feature subclass of IgG antibody that exhibits a non-inflammatory feature. Its clinical significance in allergic diseases is a complex and controversial topic with several suggested viewpoints regarding its role. One viewpoint suggests that IgG4 can act as a tolerance inducer and play a protective role during allergen immunotherapy under repeated and rapid incremental dosing of allergen exposure, supported by allergies in cat raisers and venom desensitization in beekeepers. On the other hand, the mainstream specialized and several food allergy guidelines across different countries accept another viewpoint that food-specific IgG4 is a bystander in food allergy and should not be used as a diagnostic tool in clinical practice. However, studies on eosinophilic esophagitis have revealed a direct clinical relevance between physiopathology and serum IgG4 in cow milk and wheat. Laboratory methods in cytotoxic reactions are focused on identifying antibodies of various classes that target different cells and their components. For instance, the COMS reaction helps detect anti-erythrocyte antibodies, while antibodies to desmoglein are identified through vesicles, and glycoprotein antibodies of the glomerular basal membrane are detected in Goodpasture syndrome. However, there is currently no diagnostic procedure available to determine allergic reactions caused by a type 2 hypersensitivity mechanism. Laboratory methods for type 3 hypersensitivity include two main approaches: examining tissue biopsy specimens with immunofluorescence to determine immune complex deposits in the affected organs. The localization, composition, and nature of the immune complexes are assessed. This examination provides critical information regarding the severity and prognosis of the disease. And next, detecting circulating immune complexes in blood or other body fluids. However, determining circulating immune complexes is not informative for diagnosing allergic reactions of the immune complex type. Laboratory methods for type 4 hypersensitivity. These tests include the absolute number of lymphocytes, the absolute number of CD4 plus T cells, and the CD4 plus to CD8 plus ratio. Lymphocyte transformation test has been extensively researched as a diagnostic tool for identifying delayed hypersensitivity reactions. The procedure involves isolating lymphocytes from the patient's peripheral blood mononuclear cells and then culturing them with suspected antigens for a period of 5 to 7 days. The response of lymphocyte transformation test is measured with the stimulation index, which is an average proliferation of allergen-exposed cultures divided by the average proliferation of negative control cultures. A confirmed response usually has an stimulation index more than 2 plus, calculated based on the uptake of radioactive thymidine, a marker that is directly proportional to the degree of T cells proliferation in response to an antigen. This increased response is interpreted as a T cell sensitization, and many clinical settings and different allergens have shown positive responses. While a lymphocyte transformation test can be a useful tool to support delayed hypersensitivity diagnosis, it's currently only utilized in research settings. Enzyme-linked immunospot utilizing specific anti-cytokine antibodies and activation of patient leukocytes with a potential allergen. The ELISpot method identifies cytokine markers such as interferon gamma and cytolytic molecules such as serine protease and granzyme. Nevertheless, their usage in diagnostic investigations is limited due to their labor-intensive characteristics. Currently, ex vivo tools such as the lymphocyte transformation test and enzyme-linked immunosport assay are exclusively employed in specialized centers and are not readily accessible for regular clinical purpose. Thank you for your attention.